Welcome. For those of you who don't know me, hasn't been inflicted with my presence before, my name is David Brown. I am a training officer within Division 176. I'm a primary care paramedic and an emergency medical dispatcher with the Provincial Ambulance Service. And importantly for tonight, I'm also Div 176's resident type 1 diabetic. So we're going to be expanding a little bit on the 2-hour diabetes mega marathon that I presented a few weeks ago. If you weren't here for that, there may be a few terms that might be new or unrecognized to you. If there's anything like that that I missed, please just let me know right away. That video is up on our YouTube channel, and if you didn't see it, I would highly encourage watching it. I think it's a great presentation. I'm quite proud of it. So tonight we're going to talk about a few things. We're going to talk about medications that are common that aren't insulin. Then we're going to talk more about insulin. We're going to talk about glucose monitoring, so how people test their own blood sugar. We're going to be talking about continuous glucose monitoring, which is a bit of a side step of that. We're going to be talking about insulin pumps and then what to do with insulin pumps during diabetic emergencies. And that's sort of the crux of the talk. I think the most important takeaways from it. Really, most of this talk is just going to be targeted at being educational, informative about things that you may encounter when you're doing calls with patients with diabetes, and expanding a little bit of your background knowledge on management of diabetes. And then the last bit will really kick in for when we're doing calls as MFRs or if you're employed outside. So the usual disclaimers, I think you've probably seen these before. I don't think there's anything in this presentation that really relates directly to patient care, but just in case there is, none of it is up to date with current treatment guidelines, especially as we're getting back into doing duties. It's really important to make sure that you've reviewed the updated treatment guidelines for COVID-19. And similarly, this presentation isn't training or endorsement on any of the medications or procedures discussed. Stick to your scope of practice, only do the things that you've been trained on. So I managed to close out my chat box accidentally, so I'm just trying to pull it up really quickly here. There we go. So common medications. Probably the most common medication you'll see in patients with type 2 diabetes, or even a lot of patients that are considered borderline diabetic or approaching type 2 or pre-diabetic. So it's the primary first line medication for patients newly diagnosed or approaching type 2 diabetes. It's taken as a pill, and it has a couple actions. So its main one is it increases the insulin sensitivity of the body. So particularly in type 2 diabetes, the biggest problem is that the body is creating enough insulin, but essentially this body becomes resistant to that insulin. And so a normal amount of insulin isn't enough for the body to be able to maintain a normal blood sugar. So when metformin increases the body's insulin sensitivity, it brings it a little bit closer to that normal amount of insulin being brought back to a normal blood sugar. It also has some secondary effects. Those include decreasing the amount of glucose that's actually absorbed in the gastrointestinal system. So it helps the body just have less glucose coming in the first place. And then it also releases glycogen from the liver. And so glycogen is essentially a stored form of glucose where it's stored inside the liver. And this prevents the liver from releasing it as heavily, which helps prevent it from turning back into glucose, which helps it from increasing blood glucose. Glybride is another very common medication. It's typically added in addition to metformin, and typically only seen in patients with established type 2 diabetes. So it stimulates the pancreas to release more insulin. Most of the time, the pancreas keeps a lot of insulin in reserve in case something does happen. And so it just stimulates that pancreas to release more of that reserved insulin in reaction to a particular stimulus that happens. So as it sees the blood glucose elevating, it'll release more insulin more aggressively, which just again helps maintain those blood sugars. And so combined with other medications where you've increased the sensitivity and now you've also increased the amount of insulin that's being secreted, it can help type 2 diabetics reach a more normal blood sugar range. Some older versions of this class of drug, which are called sulfonyl, I'm not going to try and pronounce it, but you can read it. The earlier types of those types of medications had some pretty significant side effects that had been pulled from the market. That most current version of these medications are extremely safe and well used. And as an interesting tidbit that I learned along here, this almost exact same formulation of this medicine is used as a liquid as a herbicide. and is apparently a very effective one, but it's extremely safe for people to take in. So do with that what you will. This next class, the GLP agonists, are not as common. They're becoming more and more common in the United States, but they're still relatively uncommon in Canada. There's only 1 or 2 of them that's been approved here so far. Essentially what they do is bind to a particular receptor within the pancreas to stimulate it to also increase more insulin. The biggest difference is that these come in forms where they can be taken as either a weekly or biweekly injection, as opposed to a daily or twice daily pill. So you'll see these under names of like liraglutide, Ozempic, or Trulicity. I think only Ozempic is approved in Canada right now, but they're becoming more common. The other big thing is that they decrease gastric mobility. So essentially it takes more time for the stomach to empty, which in turn basically decreases the amount of stuff you can fit into your stomach, which decreases your hunger, overall decreases your intake, and assists with weight loss. So you will sometimes see type 1 and type 2 diabetic patients taking this medication or similar medications simply because of the effects on the gastric motility and just for an assistance with weight loss. Largely because diet, exercise, and a healthy body weight are really important parts of particularly type 2, but also type 1 diabetes management. So the last real medication we're going to talk about here is glucagon, and it earns a few slides because it's a fun one. So it is a naturally produced hormone that comes out of the endocrine system. It's produced in the pancreas, and it stimulates the liver to take the stored glycogen and then release the stored glycogen and turn it into glucose. And so essentially, and this is getting to the edge of my understanding, so don't ask detailed questions about this, and I'm sorry if someone smarter than me knows more about this. But essentially, glycogen is long chains of individual glucose molecules wrapped up and bundled very tightly for storage. And so what happens when you have the glycogenolysis, which is another mouthful of a word, is those chains unravel and the stored glycogen in its very compact form is released out of the liver as glucose into the bloodstream. So glucagon is the hormone that stimulates the liver to perform this action. So synthetic glucagon is typically what we'll see as a rescue medication for severe hypoglycemia. It's almost always only carried by type 1 diabetics or diabetics taking insulin. So there are type 2 diabetics who take insulin. And it's really only designed for use for patients who are so severely hypoglycemic and they're so altered mental status that they can't effectively take in anything by their mouth. So it's unsafe for them to eat by their mouth. A lot of the time they'll carry a rescue kit from home. It's given as a dose typically of 1 milligram in adults or 0.5 milligram in children. And obviously, because you need to have glycogen stored within the liver, if you have either existing issues with your liver, like liver disease, or you have just low glycogen reserves, so it could potentially be that glucagon doesn't work well twice in the same day, for example, or people who are in a state of starvation would not have an effective response to glucagon. And again, just so you're aware, it is used off-label sometimes by type 1 diabetics, especially if someone's quite sick, vomiting, just isn't able to take food in by mouth. A lot of the time you'll see them using very, very small, like 0.1 or 0.2 milligram doses of glucagon just to help maintain their blood sugars up at a normal level. It's obviously not an ideal practice, but sometimes you just sort of have to do what works for you there. So this is the sort of classic glucagon injection. So glucagon is up until very recently only been formulated stably as a powder, and so it needs reconstituted before use. So you can see this syringe on the right-hand side contains a particular liquid. It's not saline. It's a particular fluid that mixes in with the powdered glucagon in the vial on the left-hand side, and so you have to load the fluid into that ampule of powdered, mix it up, and essentially reconstitute it into a fluid, then draw it back up into that syringe and inject it into the person's intramuscular system. The big thing with it is there's a study done fairly recently that essentially showed even when people had been trained on it only a week prior, in an emergency situation, only about 13% of people could actually use it properly, and nobody who hadn't been trained on it previously was able to use it properly. It's definitely something that's not been as well advertised as EpiPens, but it's also definitely something that's not as straightforward and simple as EpiPens. Most family members do have an awareness of how to use it, but again, many people don't have to use it for their entire lives. So it's a skill that goes stale like any other. But thankfully, there are some alternatives coming out into the world. So this is a medication called Baqsimi. It's an intranasal form of glucagon. So it's stored as a powder, and it's essentially a powder that reconstitutes itself in the nasal secretions. So this is mine here. You can see it's about the size of a very tall film canister. It's extremely compact. I'm not going to open it because it's shrink wrapped to seal it. But again, it's designed to be a simpler tool. It's also much smaller than the glucagon kits that are about the size of an EpiPen bag, if you ever had to deal with one of those. And the real idea is anybody can figure out how to stuff something up your nose and then squeeze it. So that's a newer alternative. The big thing is the glucagon kits cost about $20, whereas this one costs about $140, and they expire every year, versus the glucagon injection kits have an expiry date of every 2 to 3 years normally. Also worth mentioning, it's not approved in Canada, but the geniuses at Xeris Pharmaceuticals have figured out how to make glucagon stable as a liquid, and they've made an auto injector of it. So now in the States, and I believe coming to Canada sometime in the next year or two, is what's called the Givo Hypopen. And so it works very similarly to a EpiPen auto injector. You just pop the red cap off and inject it right into the muscle there, which is just another cool tool there. Do we have questions about medications that are not insulin? Take a quick break for those here. I'm going to drink some water.
There's one in the chat. Shirley, I'm not quite sure what you mean by your question. It says, what does empagliflozin or trade name Jardiance? And I think there's a part of the question missing there.
Sorry, what was the question? One more time.
I'm not totally sure if you want to pull up the chat. Shirley, do you want to?
I think it might have been sent to.
Oh, what does it do? What does it do?
I am not 100% familiar with that medication. There are a lot of different medications out there. Like, I'm really just trying to hit the most common ones, because we could talk about every single medication of all of them. From a very quick Google, it looks like it is another sulfonylurea, so related to metformin. Yeah, it looks like it's another fairly standard anti-diabetic medication. So a lot of these medications that are meant for type 2 diabetics are sometimes used by type 1 people with type 1 diabetes for any number of reasons. There's a number of people with type 1 diabetes that take medications like metformin for that increased insulin sensitivity. And because insulin is a hormone, it has quite a few effects. Like, it is an anabolic. It affects your fat storage, so it actually decreases your body's ability to convert fat into energy. And so because of that, it makes it harder for people to lose weight. It does add some ability to gain muscle for certain people. So sometimes people with type 1 diabetes who are trying to lose weight or any number of things, reduce their insulin intake for one reason or another, might take some of these medications that increase your insulin sensitivity, because it helps them take less synthetic insulin over time. Similarly, some people will take medications that increase your pancreatic output. Like myself, as a type 1 diabetic, I still produce, like, I don't produce much insulin, but I do still produce a little bit. My pancreas is still trying its best, flailing away there. And so some people with type 1 diabetes who are still in that stage, it's called honeymooning, where your pancreas still has some effect, will also take medications that increase your pancreas's output, again, just to try to maximize the natural insulin that you're using and reduce the amount of synthetic insulin that you're taking on. Brian asks, would emergency medical dispatchers ever talk somebody through using this? No. So all these medications, the glucagon injection kits are quite tricky to use. And the other big thing to mention with glucagon is it is a hormone and it has quite significant effects on the body. And if someone has gotten glucagon, this is actually a point I missed on my slides. If somebody has gotten glucagon, they must go to the hospital and they will probably spend a night in ICU getting monitored before spending a day or two on the floor. It's not a medication that you would ever want to give somebody unless they are truly unconscious, completely unable to take in food by mouth, and there's going to be a significant delay for a higher level of care, bringing something like intravenous glucose that we carry on the ambulance. It's a really rough medication on the body to take, and so we try to prevent using it as much as possible. Like we carry it, like it's within the primary care paramedic scope of practice, and it's really a last resort medication, either if somebody is deeply unconscious and that we can't get intravenous access, or the other one is if somebody is so altered that they've become combative or aggressive, and potentially somebody like the police have to restrain the patient. And so at that point, it's not practical to try and get an intravenous and get IV glucose into them. So that's another opportunity we might use glucagon. But typically, glucagon is only used by family members in severe emergencies. I largely carry my Baqsimi or the nasal glucagon for hiking or backcountry trail running and stuff like that, where I'm a significant distance from a higher level of care. And so while having one of my partners use it on me would be less than ideal, it's the difference between laying unconscious on the trail for a couple hours while we're waiting for search and rescue versus being able to kind of hobble out carefully to go meet somebody out at the road. So it really is an emergency rescue medication versus a commonly daily used medication, which is a long way of saying no. Over the phone, just 911 ambulance dispatch will not talk people through using any of these medications. Nancy asks if people have to check their blood glucose and adjust these medications accordingly. So people with type 2 diabetes, the management tends to be very different. A lot of people with type 2 diabetes taking oral medications will either check their blood glucose once to twice a day just to make sure they're monitoring where they're going. But a lot of the time it'll be monitored through lab work over a period of months. A lab called your A1C, and again, it's a very long word that I'm not going to try and pronounce, but it essentially measures how much glucose is bonded to sites on your red blood cells, and it's effectively a good measure of what your average blood glucose has been over about the last 2 months. So a lot of the time people will get some baseline labs, find out their A1C is high. It's in the 7s, 8s, 9s, which is quite high for a normal person. Normally we'd expect someone who's not me in this chat would probably be between about a 4 and a 5. And so they would draw those medications. The first week or month they were taking them, they would check their blood sugars to make sure they're not overcompensating with the medication. And after that, they would just be following along with those A1C measurements to make sure that they are staying within the right range there. Everyone's diabetes is different. Everybody's management is different. Lots of patients with type 2 diabetes do check their blood sugars more regularly, but it's not something that's as common because these medications act over hours to days. Like the half-life of metformin is about 18 hours. So it's not something like insulin where you have to take it super regularly and carefully monitor the effects. Any other questions on medications before we move on? Great. We can always circle back to if anybody thinks of anything else that's along the way here. So insulin, the magic bug juice that keeps me alive every day. So first off, I would like to shout out to my friend, Sir Frederick Banting, a Canadian who discovered insulin. If you're not familiar with the story, it's pretty incredible, and it's something I'm going to try and put out there. So he's a scientist at the University of Toronto, and he was the person that really figured out, working actually, I think in cadaver labs, that there's a connection between the pancreas and regulation of blood glucose, and then put together with that the fact that the magic pancreas juice probably would help with blood sugar. And so initially they actually took a couple dogs from one of the labs, they took some of the dogs from the lab and took the insulin directly from their pancreas and basically walked over to the hospital at the University of Toronto and just started injecting this into children who were dying of diabetes in the ward there. And it was a room filled with children who were largely in ketoacidotic comas, unconscious, wasting in front of their families. And one by one, these kids just started to wake up all around the room. And conveniently, this year, we're coming into the 100th anniversary of the first dose of insulin. And at the age of 32, 2 years afterwards, in 1923, Sir Frederick Banting became the youngest ever, and still is, the youngest ever Nobel laureate for medicine and physiology. And he was actually knighted by King George 2 years after that. The other thing that's worth mentioning, especially in the context we see of the price of medications, and particularly the price of insulin in the United States, is that he actually sold the patent for insulin to the University of Toronto for $1, with the express intent that it would help keep the price of insulin manageable for the people who need it. Obviously, that hasn't worked out, but a really incredible scientist, a really great guy. I mean, I don't want to dive down the whole rabbit hole, but if you have some time, the Toronto Star did a really great deep dive piece. I'll have Nick link into the YouTube video. It's really interesting actually reading about the process behind and the people he was working with. My headphones falling out. So pre-synthetic insulin. So pretty quickly after they discovered that Magic Dog pancreas juice worked well to regulate blood sugars, they started trying different animals, and they found that pigs and cows actually had the closest correlation or the highest effectiveness in humans. And that's largely because we share the most genetic material with pigs and cows. And so the parts of the pancreas that the insulin acts on are much closer related than dogs. And so up until the 70s and even going into the 90s, though it became less common by then, at slaughterhouses, one of the things that was saved was the pancreas. And the insulin was removed from the pancreas of pigs and cows. It was processed, cleaned, sterilized, and then loaded up into vials for injection. So the big thing is because bovine and porcine insulin were not really that well linked to humans, and they're not particularly similar to human insulin. Their effects were unpredictable, and especially too, like, it was very challenging because for them to make effective concentrations and balances. So every time people took an injection, it was a little bit of a cross your fingers and hope it worked out. And it also did create some moral and religious concerns for some patients. A lot of people don't feel comfortable taking products either from cows, pigs, one or both. And yeah, animal insulin, I think, officially stopped being used in Canada in 1995 or 1996. So really not that long ago. Thankfully, we now have more modern synthetic insulin, and it's made in a lab, and it is a GMO. And I'm sure there's a few people out there who are taking insulin who will not possibly eat some genetically modified carrots and are in for a world of surprise one day. But scientists have figured out how to genetically modify certain animal and plant cells in huge vats where they just constantly secrete insulin that is bioidentical to humans. And so because it is functionally the same insulin that the human body is used to, it functions much more reliably and much more consistently in the body that way. So as we're talking through names, this is not an exhaustive list, but it's a pretty good one. These are all different types. These are the most common insulins that I could find in Canada. So these are almost all, actually, no, sorry. These are all going to be brand names. Canada doesn't really have generic insulin outside of Humulin. And even then, I believe that's a generic made by Lilly, not by a generic company. So types of insulin. So now that we have synthetic insulin, there's functionally two different types of insulin that we talk about differently. So you have your short-acting or bolus insulin and your long-acting or basal insulin. So the basal insulin is designed to replace just your body's underlying mechanics, all the little acts of digestion and your ongoing, little bits of glycogen that are being released from the liver, things working their way through the digestive tract, releasing glucose into your body, all of those different systems. And so your basal insulin is a single dose taken once a day at about the same time of day. And it's there to just cover that. And it's designed so it releases consistently over about 20 to 22 hours. So it lasts effectively the whole day. Short-acting or bolus insulin is what most people think of when they consider insulin. And so and there are different speeds of action within the broad category of fast acting or short acting, fast acting, or bolus insulin. So it has an effect within 10 to 20 minutes, but it still takes 30 to 90. Most insulins take about 45 minutes to an hour to really reach their peak. And that's what's going to be taken to cover essentially anything coming into the body. So if I wanted to go eat 3 Oreos right now, I would take my 2 units of short-acting insulin. I had some chicken for lunch that was about 4 units of short-acting insulin. And that's the real one that you're playing a balancing game with, because you're trying to take, and we'll talk a little bit more about dosing, but you're trying to take just the right amount of insulin to cover off the carbohydrates coming into your body and all those balances. So there's a couple different ways of administration of insulin. So all of these, except for the last one, provide your insulin subcutaneously. It's different ways. So I think the most traditional way people think of is with the needle and vial. So you've got the vial of insulin, you draw up out of a needle, pinch up the skin and inject it subcutaneously. So you're injecting it into the layer of fat that sits below the skin and above the muscle. People typically give it subcutaneously into their stomach, but you can really do it anywhere that you can get you can sort of see a pinch of fat up onto the body. As well, there are insulin pens. So this is one of my insulin pens, for example. So I don't know how you can see this. It's Humalog. It's actually the junior version because I'm a special big boy. So on the end here, so this is a vial of insulin. And you can see that there's the plunger in here. So what I do is I have a dial, and so this one goes in half unit increments. So I would dial up how much insulin I want. Then once I've done that, I take a needle, and I'm sorry if you can't see this very clearly, but there is a film at the end here. And so this needle has a needle on the inside that goes into the vial, and it threads onto the top. And then as the cap comes off, you can see there's another needle on the top here. So that needle goes into the skin, and then you depress the plunger, and it will just meter out exactly that many units of insulin. So these are, I think, probably the most common form of injection insulin. People taking like needle and vial insulin isn't too common in Canada. The big thing is these are significantly more expensive than a vial of insulin for the same amount of fluid. So this one has 3 milliliters of insulin inside of it, and it costs about $25. Versus a vial of insulin costs, a vial of insulin has about 10 milliliters of insulin within it, and it typically costs anywhere from $30 to $35. But that said, the sheer convenience factor of having the pen outweighs it for most people. So you can see we've got some other insulin pens down at the bottom. And then just for context as well, I have a separate insulin pen that has the basal insulin in it for me here. It's a different color. Typically different brands of insulin are different colors in their pens. There's not one color for bolus insulin and one color for basal insulin. Insulin pumps we're going to cover later, but it's a way of doing it. And then not particularly common, but it is still out there, is these Afrezza inhalers. And it's exactly like that. It's the strangest looking vape you've ever seen, but you load in a cartridge with however many units of insulin that you want to take. And then because you're inhaling it, it reaches the system very quickly through the respiratory system. And so it has an uptake, it begins its effect within about a minute of the inhalation. So a lot of people will use that either for last minute or impulsive things, or if they're just going very high very suddenly and need to quickly get extra insulin on board to try and manage that. It's not particularly common in Canada, but you do see it from time to time. It's still quite new and it's extremely expensive still. And it's not covered by, I believe, it's definitely not covered by BC Pharmacare, and I don't believe it's covered by most extended insurance either. So insulin dosing, we're almost through the insulin section here. Insulin is dosed in a very arbitrary unit that's called units. And I spent probably 20 minutes researching last night and just could not find out what the actual meaning of a unit is. It's not a particular, like, there is no, it's a unit, and insulin is just talked about in units, and that's just the way the world seems to work, to be honest. So the vast majority of insulin is going to be 100 units per milliliter, or U100. It does also exist in U200, so 200 units per milliliter, and U500. Those are just going to be for patients who are severely insulin resistant and just need so much insulin. Like this, for example, this pen is U100. It has 300 milliliters in it. Or sorry, pardon me, it has 3 milliliters in it, and it lasts me about 20 days. And there are some people, particularly with type 2 diabetes, who are extremely insulin resistant, and they can go through that pen in a day. And so they need these much higher concentration insulins to just deliver that much more insulin without injecting 5 or 6 milliliters of fluid into their body every day. Insulin is, or the bolus insulin is delivered in a fixed ratio of carbohydrates to units of insulin. So every diabetic is different and everyone's diabetes varies, but most people have a ratio. So for me, it's 1 unit of insulin for every 16 grams of carbohydrates that I take in. And so if I'm eating Ruffles chips is a great example. It's 30 grams of carbs in 50 grams of chips. So I know if I want to eat 50 grams of chips, I need to take about 2 units of insulin. And there's a little bit of wiggle room within there. And a lot of it becomes just trial and error, finding the right ratio. And all of that gets skewed off with any number of things. If you are sick, your insulin needs can go up, but then sometimes they go down. If there's a lot of fat in the meal, fat also breaks down, but it breaks down differently. So you might have to take less carbs earlier. It can depend, not even joking, on the temperature outside. It can depend on how hydrated you are. It can depend if your mercury's in Gatorade. Like, it depends on all these different things. So these ratios are a general guideline, but you can have your ratio absolutely nailed, and one day it'll just stop working for you. And I know this hasn't been a particularly a particularly visual demonstration. So I put a meme in there for you guys for something to look at. Any questions about insulin? And while we're waiting for questions, Anna, if you want to do your roll call, might be a good idea now.
Yeah, absolutely. So right now we're gonna take a quick break for attendance. So again, this is for you folks who carry licenses with EMALB, and you need to collect credits for the 2021-2022 year. So the way we can prove attendance is if you type your name and your email into the chat box. So for the next minute, if you want a certificate, put your first name, last name, email all on the same line in the chat box. And once a minute passes, I'll close the attendance, and then we'll get those certificates sent out to you. Generally, these sessions are 1 credit, half a credit, something like that, depending on which NOCP it gets filed under. So if you need a certificate for this year, it's right at the start of the year. Type your name, email, all that stuff in there right now.
The other thing I'll just throw in there while people are typing is I'm working on a bit of a variation of this presentation combined with the previous presentation, specifically aimed at healthcare providers and people working in frontline first aid medical care, around more aimed at the second half of this presentation, but a little bit at the first one. So please, if there's questions that are coming up, or later you think of questions or things that I hadn't covered that you wanted to know more about, please do send me an email. It was in the invite for this chat, or send an email to Anna and let me know, because it's something that hopefully is going to be getting repeated and shared a little more broadly. So we're hoping to really have it polished. So not to say I'm experimenting on you guys with it today, but we're experimenting a little bit today.
All right, we'll call time on that attendance and let you carry on.
All right, good job, everybody. Thanks for coming out. Glucose monitoring. This is a bit of, if folks who do carry licenses, this will be a little bit of a review, but it's worth going over. And again, it's something that I think everyone should have at least an awareness of. So capillary blood glucose is essentially what it says right on the label. So it's taking blood out of the capillaries, typically in the fingers, and measuring the amount of glucose in the blood there. So it's used a lancet. So you'll see lancets that are quite small. This one's mine. It's very large. It's spring loaded. And it makes, I don't know if you can hear, it makes a really satisfying little snap when you use it. So essentially what this does is it just draws back a spring with a small needle. You hold it up against your finger, press the button, and a small needle swings out, stabs your finger and pokes it there. And then again, the glucometer you can see on the screen there is one. This one's mine. It's quite small. And it actually Bluetooths to my phone, which I think is just absolute magic. So when I do use this, it transmits the readings directly to my cell phone, which makes it really easy to track and log. So you just take a test strip that has a very small hole. You can see it on the end of the ones on the picture here. It sucks up a tiny bit of blood and it measures your blood glucose. You'll also hear these referred to a lot as a finger stick, a one touch, or a CBG. As well, people will also just typically call this, did you get a sugar or did you get a glucose? This is by far the most common form of glucose testing that happens in healthcare. And it's generally used as a sort of first line check. So for example, when I showed up to the hospital when I was very first diagnosed with diabetes and didn't know I had it, one of the screening things they did with my symptoms was just a quick finger stick at the triage desk. That came back extremely high. And so then they drew blood and sent it to the lab to confirm that. But the technology that you guys can learn about today is called continuous glucose monitoring. And so these are medical devices where a small wire is inserted underneath the skin. And so it sits in the, right in the lower layer of the skin and going into the subcutaneous tissue there. So again, and these can go anywhere you have a pinch of fat. And it measures in the interstitial fluid, essentially. It's a conductive wire. It sends a, and again, I'm not going to pretend to understand this in much detail, but it sends a very small electrical impulse down there, and then it can actually detect changes in the resistance within the interstitial fluid and translate that through magic and science into a reading of a blood glucose. And then most of the models on the market take a reading every 5 minutes. And then depending on the particular continuous glucose monitor or CGM that you have, it'll either push it to your phone. So the one I have connects to my phone directly, or some of them you have to scan with your phone or a dedicated receiver if you don't want to use a cell phone. So mine measures my glucose every 5 minutes. It gives me a nice little trend. I'll see, I don't think mine's too embarrassing today, so I'll pull it up on my phone and kind of show you. Yeah, so you can, I apologize if you can't read it too well on the screen here, but you can see my sugar was quite high today and I was out for a run, so I was pretty okay with it and let it come down. And it's tracking nicely. That's the 6 units of insulin that I took with my dinner. And then we're sitting at a nice 6.8 right now, which I'm not worried about. But it's similarly, if my blood sugar starts to go high, so when it was drifting high earlier, it sends me a little friendly alarm saying, hey, your blood sugar is a little high. You should do something about that. And when it starts to go low, it gives me a friendly little alarm letting me know that it's, hey, I'm a little worried about you. And then when it starts dipping really low, so down to about 3.1, it gets very angry and actually sets off a non-mutable alarm, which is really designed to wake you up in the middle of the night if your blood glucose is going super low. They are a really incredible tool. I can't overstate that. This being able to understand what's actually happening and seeing trends in your blood glucose versus just 4 finger sticks a day does make a big difference in being able to actively manage your diabetes. So in Canada, we have 2 continuous glucose monitors that are on the market. The one on the left is the Dexcom G6. That's the one, I don't know how you can wear it. I'm wearing on my arm here. It's there. So that one is the one I'm wearing. It continuously pushes to your phone. The one on the right is the Freestyle Libre. The Freestyle Libre is significantly less expensive. The Dexcom, I pay $300 a month, which is an already reduced price for mine, whereas the Freestyles are about $160 a month. It's by no means an absolute rule. A lot of the time, people with type 2 diabetes wearing a continuous glucose monitor will use the something like the Libre because it's a lot less expensive and they're less likely to have those severe hypoglycemic events where they need that early warning system that the continuous monitors provide. They can be officially, particularly with the Dexcom, it is only approved in Canada for use on the stomach. And so some people do wear it there. I wear mine there sometimes. It just all depends. That said, because it just needs to be in subcutaneous tissue, essentially you can wear it anywhere that you do have a pinchable amount of skin. So I wear mine on my arm quite frequently. I have fairly lean legs, but a lot of people find it's quite comfortable on their leg, like their upper thigh. Some people wear it on the top of their buttock. A lot of people wear it over on their hip as well, really anywhere you can find that pinch. And so these are, again, there are some other medical devices that attach to the body and look similar. But when you're dealing with an undifferentiated patient with an altered level of consciousness, if you just, as part of your, your body, rapid body survey, coming across something like this is going to be a strong indicator that you should be considering diabetes as part of your differential. So they do have limitations. Nothing is perfect. The world is not perfect in any way. So interstitial fluid is basically the last chain as fluid moves out. So if you think your aorta has the freshest supply of blood because it's pumping the brand new fresh blood out to the body, with all the new glucose being released from your central system, so from your GI system, from your liver, and then it works out to the veins, out to the then out to the capillaries, and then finally out into the interstitial fluid. And so even compared to capillary blood glucose, which is a pretty effective like live update, the interstitial fluid glucose is a bit of a delayed reading. So typically about 5 minutes behind, although it can be up to 10, especially in people who are severely dehydrated and so they don't have a ton of interstitial fluid going around as well. They can be affected by a number of things as well, so thrown off. Temperature, if it's particularly warm or particularly cool, essentially your skin reacts to that. When it's very warm, you become flushed. Trying to burn off heat, you have increased blood flow out there, they'll be a little more accurate. Whereas typically when it's very cold, you have reduced blood flow to your skin. They will become less accurate because there's less continuous, there's less fluid being exchanged within the interstitial fluid. It's less common now, but some people are still on some older models that can be affected by certain medications. So NSAIDs like Tylenol and Advil significantly affected the accuracy of the previous model of this monitor that I'm wearing. That's largely been resolved, but it's just something to keep in mind loosely. Sometimes they can also just be inaccurate. So the only the requirements by Health Canada is that they have to be within 20% of a lab drawn reading all of the time. Dexcom advertises that they're within 10% 98% of the time, and with that 20% 100% of the time. But every so often they are just a little off. It's just sort of the way the world works. And so that's where these newest generations of continuous glucose monitors, so the one I'm wearing, the Dexcom, as well as the Libre that you saw there, Health Canada has endorsed them for making treatment decisions off of. So previously they were only really good for giving people a general idea of what was happening, but the company specifically suggested that you do a finger stick to confirm the reading before you gave insulin, whereas now it's approved for that. But every manufacturer will tell you to verify the insulin with a CBG or a finger stick if the symptoms you're seeing in a patient don't match the readings. So if you have a patient who really looks like that classic altered diabetic, they're pale, they're sweaty, they're loopy, they're not really making sense, and you're strongly suspecting a hypoglycemic event, and a family member pulls out the person's phone and says, no, look, their sugar's completely fine, it can't be that. That's where, especially if you have somebody, either if you're with St. John who's carries a license to do that, or you're working in a work site with that, I would double check if your symptoms aren't making sense by doing a finger stick, because that is always going to be your gold standard accuracy there. Questions there. I see Kyra says, how easily can CGMs be ripped out by accident? Very. So just linking on to what Nancy was also asking below. So the one I'm wearing is good for, has to be replaced every 10 days. And so I'm quite athletic. I do a lot of hiking, running, and I'm also a fairly sweaty person to begin with. So when I'm putting mine on, I have to shave the site that it's going on to. I exfoliate it pretty aggressively, then get it with an alcohol swab, both to make sure it's clean and reduce a lot of the oil buildup in that. Then I take a special wipe, it's called Skin Tack, and it's specifically designed, funnily enough, to make your skin more tacky and stickier. And then I stick it on. I don't know how you can see. I put this one on 2 days ago, and it's still quite clean. The edges are quite well secured. But when as soon as one of those edges starts to peel up, typically in a day or two, I'm just reaching into my big box of diabetes supplies. I've got these overlay patches that basically just go over the adhesive and just help stick it on. Especially when it's been on for a few days, it is quite possible to rip them off. Sometimes they fall off. The companies are really good at replacing them. So I've had one that I put on that just stopped working, and they've replaced it, and it's being FedExed to me right now. But they can be ripped off by accident. On the arm, it's quite easy. If you're like taking off a t-shirt or something, to just hook it on there, and there is a small edge that can catch, and then just peel it right off. It hurts. Not so much from the wire. Like, the wire is very small and it's very flexible, so it just sort of peels right out. But it's adhesive, and I've put a lot of work into sticking it very well too. Nancy's asking, how comfortable are they to wear friction against clothing? I found the very first one that I put on, I was hyper aware of it. And I had it a little more on the outside of my arm, and I did not realize how close I walked to doorways all the time until I started hitting it on doorways constantly. But honestly, now it's second nature. I don't particularly notice it most of the time. I do have a little more chub on my belly, and so sometimes I put it on the wrong spot where it's sort of right where it wants to roll. If I'm bending forward to tie shoes or stretching or something like that, I notice it. Doesn't really rub against clothing. It stays put pretty well. Some people really struggle with reactions to the adhesive. I'm lucky that I haven't before. But some people have to put on like special bandages underneath it to keep the particular adhesive from going on there. For placement, for Kyra's question about placement, like I think I sort of touched on this earlier. So for the one I'm wearing, Dexcom specifically in Canada and the US only has it approved by Health Canada and the FDA for being worn on the stomach. But that said, in the UK, it's approved to wear on the arm, and it's the exact same thing. So there is not a functional difference between where you put it. It will work almost identically anywhere. But that said, there is a hypothetical case where if something happened, something all went wrong and it was on your arm, you probably wouldn't be as well supported by them. I know a lot of people aren't afraid to just, no matter what, if they're phoning into tech support, you say that it's on your stomach, and that's a normal thing for some people. If you're watching Dexcom, I don't do that. Any other questions about these continuous monitors? Great. So we're in the home stretch here now. We're going to talk about insulin pumps. This is the fun part. So the basic idea of an insulin pump is it is a medical device. It has in the body a reservoir that contains insulin, and then a small cannula. So it's typically a flexible piece of plastic that's inserted into the subcutaneous tissue, so into that layer of fat again, and then attached by tubing to the body of the insulin pump. And then the insulin pump is what pushes the insulin through the tubing, through the site, and into the tissue there. So it replaces the injections that way. They cost many thousands of dollars. They're extremely expensive. And some of them are approved by BC PharmaCare, and then there's a few that aren't, unfortunately. So it's a large upfront cost, plus the between sites, reservoirs, and insulin, they typically cost an ongoing $200 to $300 per month in supplies. So the cannula is replaced every 2 to 3 days because it's a significant piece of plastic that lives under the skin. Plus, insulin can start to degrade fat and get funky stuff. If you start leaving it in for longer, it runs both an infection risk and a risk of significant scarring in the area, which means you're not able to inject your insulin there either. So like anything else that uses these subcutaneous tissues, so either injections or these continuous glucose monitors, it can really go anywhere you have enough fat to be able to pinch up a little bit. Most people do wear their insulin pump sites either on their stomach. Some people do also wear them on their hip or on their upper buttocks. But typically most insulin pumps are worn on the belt with the body of the pump, or in your pocket. And so just those spots around the abdomen are going to be the most accessible. You do see sometimes people will loop tubing all the way up to their arm or down onto their So these essentially work similar to an IV, if anyone's familiar with the way like an IV cannula works. So there is a metal needle surrounded by the cannula. The needle and the cannula insert together, and then the needle withdraws, just leaving the cannula in place underneath there. There are some people that use just a steel cannula, and so it's a small steel needle that the insulin delivers down the middle. They just place that into their skin and leave that there. And a lot of people who either have issues with absorption or people who are very lean and don't have very much body fat find that to be more comfortable or more effective for them. Everybody's a little different, but this picture here you can see is functionally what most insulin pump sites will look like. And so you can see too, the sites disconnect at the tubing disconnects from the site at there as well. And that's because most insulin pumps are not waterproof. So for stuff like showering, going swimming, things like that, you have to disconnect from your insulin pump so you don't drown it. So how do insulin pumps provide insulin? So they do two separate things. The first is they replace the basal or long-acting insulin by using fast-acting insulin. So for example, if a patient takes 24 units of basal insulin as an injection per day, essentially what an insulin pump will do is take 1 unit of fast-acting insulin and just administer it over an hour every single hour to act in place of the basal insulin. And so especially for people who find either some things like exercise or any number of things cause them to go low, what they can do is just for that period of time, reduce the amount of basal insulin that they're receiving to try and counteract that. Typically, it's going to be no more than about 2 units per hour of basal insulin that's being infused over an hour. Anything more than that is quite high, and I would say relatively uncommon. And then otherwise, they also include a bolus calculator. And so the pump knows how many, like what your insulin to carbohydrate ratio is. So it knows your carbohydrate ratio insulin to carb ratio is as detailed as 1 unit of insulin per 16.75 carbs. And then you can tell it that you're eating 42 grams of carbs, and it will calculate out the exact amount of insulin that you need for that to cover that off really in a detailed level. Which is just a really helpful feature and takes some of the brain work out of it. And so some of the newest pumps, and sorry, that is the way pumps have worked for a very long time, and that is the way most pumps out there still work. 2 of the newest pumps are what's called hybrid closed loop. And so that's where the pump is actually connected to the CGM, and it adjusts your insulin delivery based on rising or falling glucose readings. So if the pump starts to see that your continuous glucose monitor and your glucose readings are starting to go up, it'll slowly start turning up the insulin that it's giving in the background to try and counteract that rise. And the same, if it sees you start to fall and it thinks you're about to go low, it'll dial back the insulin or eventually cut off the basal insulin entirely to try and maintain your blood sugar in a normal range. So that's really only become available in Canada, approved by Health Canada in the past year. And it's really the cutting edge of retail insulin pumps. For about the past 5 years, people have been doing what's called looping or hacking old insulin pumps, and then basically using their own transmitters that are linked to a cell phone and doing that hybrid closed loop work on their own in the background. It's really cool stuff. It's not something I've ever felt comfortable trying because it's not something I'm fully on board with, but a lot of people have really good results with it. And a lot of people find really good success with that. So you may again encounter a patient that says, oh, they're looping with their pump. You just need to know essentially it's a DIY process where they have that insulin pump that's being controlled by a cell phone linked to a continuous glucose monitor. Typically, patients who have that system set up are very well educated about it and they're able to troubleshoot it on their own. No one's really going to be asking you to help troubleshoot an insulin pump in the field. And we'll talk about dealing with insulin pumps a little bit, but the very short answer is you just don't try to deal with an insulin pump. So in Canada, there's 4 insulin pumps currently on the market. We're just going to talk about them really quickly. So the first one to talk about is older pumps. They almost all look exactly identical to this one. They kind of look like a weird pager and they come in different colors. They have very limited features. Like they're very much designed to just do exactly what we were talking about before. They give the basal in the background. You can set a temporary basal rate on them, so higher or lower if you want, and you can give a bolus of insulin, and that's all they do. And they really came around in about the mid 90s. So for pumps that are currently on the market, so these are the ones you're likely to see out there. This one's the IPSO pump. It's quite new in Canada. It's bonehead simple, and it's really designed to be smart that way. So it's just a small touchscreen with a couple of buttons. It has the basal, and it's really designed to be compact, easy to use, and user-friendly. It doesn't have any of these advanced features, and it's really marketed towards people who are wanting a simple device to be able to manage their diabetes easily and effectively that way. They're still not particularly common in Canada. They only really started selling them about 3 or 4 months ago, right at the beginning of 2021. But you're going to start seeing them around more and more, particularly because this pump is now covered by BC Pharmacare. So I suspect we'll start seeing it more and more. This little guy is called an Omnipot, and these are actually really interesting because it's an all-in-one device, and it's a disposable pump. So every 3 days, you take the entire thing off, throw it in the garbage, and fill up a new one. It is designed so it can be worn anywhere that has enough subcutaneous tissue. So you can see this person's wearing it on their leg. A lot of people wear it on their arms. Some people wear it on their upper pectoral where they have a little more tissue there. Some people, again, anywhere that you can get a pinch of fat. And because it doesn't have tubes as an all-in-one system, a lot of people prefer it just for the convenience and simplicity there. It is controlled with a separate device. The newest generation of them run off of like a blocked out cell phone, essentially. You can't currently use your own phone to manage it, although allegedly that's coming at some point. The older generation of Omnipods can also be hacked and looped, like we were discussing earlier. And that, so again, just worth mentioning, someone may mention that they're looping with an Omnipod. That's just what they're talking about. They've replaced the transmitter with a third-party tool called a Riley link, and then it's controlled by their phone. Their phone's connected to the continuous glucose monitor, and their phone's telling it how to do the adjustment for insulin based on their glucose reading. The Medtronic pumps, so there is the 670 and 770. The 770 is current. Oh, and sorry, just going back to Omnipumps for half a second. Omnipod is the other pod that is covered by the other pump that's covered by BC Pharmacare and BC Health Insurance. So these two are in this almost the same case. They both look functionally identical. There's just some very small changes. They are in the newest generation of pumps that are that hybrid closed loop. So these pair with Medtronic. They have their own continuous glucose monitor. That's not too common. It's not great, but it adjusts the basal dosing in the background to accommodate your glucose levels. This pump is covered under BC Pharmacare only if your doctor is willing to write a letter explaining that the other two pumps aren't suitable for you for whatever reason. It's not too common, but it is seen there. And then the Cadillac of pumps available in Canada is the T-Slim X2 from Tandem. So this just hit the market a few months ago in its most current form, but it is currently considered the smartest pump. So it partners with the Dexcom G6, the continuous glucose monitor, and it provides the basal rates. But it also, if it sees your sugar is going very high and thinks it's going to be completely out of range, it's actually set up so it can deliver a bolus of insulin. So it'll provide like a large chunk of insulin instead of just playing with the background basal rates to try and get your sugars back under control that way. And the other big thing too is this company, Tandem, is doing a lot of really cutting edge stuff around both these hybrid closed loop systems. So theirs is considered to be the sort of most accurate and most effective, as well as some of the stuff they're talking about doing in the future with their pumps is really interesting. They're the only ones really talking about like adding control from your cell phone, so you could bolus from your cell phone instead of having to push buttons on your pump and do all of that. So yeah, just a point of interest. This pump is not covered by BC Pharmacare at all. I'm currently negotiating with my insurance company to try and get it covered through my private insurance, but it is $7,000 upfront for something that is quite small but very, very smart. I guess let's just quickly pause and see if there's any questions specifically just about pumps. We're going to talk about treating patients with pumps and all that in just a minute here. Kyra's only question is, can these Bluetooth pumps be hacked? In the sense of like, if you want to intentionally link into them and connect to like manually do it, yes, it's possible. When there was the last, in terms of like vicious hacking, I don't think so. There was the last big Bluetooth vulnerability, all these companies put out statements saying essentially their pumps weren't affected by it. And even then, I think you would have to do something quite sophisticated to somehow trick the pump into believing that the sugar reading it was getting from the Dexcom was super high. It would be a very strange, very specific thing to hack. It's certainly not something where a hacker could just hack into the pump and deliver 50 units of insulin to try to wipe you out in the way. But so the only reason you don't have one is I don't have one is cost. Largely, yes. I just got back onto benefits relatively recently. Those who work through the provincial ambulance service will understand the struggle. Some people are quite happy managing their diabetes with injections. A lot of people aren't comfortable with the idea of having a device permanently attached to your body. A lot of people have very successful management with injections. Not to brag or anything, I have extremely good numbers just managing on injections, but I manage doing probably 7 to 8 injections of short-acting insulin plus an injection of long-acting insulin every single day. I am an active participant in managing my diabetes, whereas some people will just take 3 shots of fast-acting insulin a day with their meals and kind of call it good and hope it works out. As well, yeah. So lots of people prefer not to have a pump. For me, it's something I've wanted for a little while. I think it'll be different for me, but everybody's different. But yes, the cost is a big factor in it. I'm not in a position to pay that upfront. And similarly, the ongoing cost every single month. I pay $300 a month for the Dexcom sensors that aren't covered by PharmaCare and are only partially covered by my extended health benefits through work. I'm just not in a position to take on another $300 a month in supplies plus the upfront cost of the pump. So we're almost there. Two more slides that you have to pay attention to, and then I'll get out of your ears. So insulin pump failures. So this is one of the things we run into a lot with patients who are experiencing hypoglycemic emergencies that are on an insulin pump. There's always a little bit of concern that maybe it was an insulin pump malfunction when they can't explain what happened. And the short answer is it's very unlikely that it's actually the pump's problem. The FDA investigates anytime someone believes that there was a significant illness, injury, or death caused by a medical device. So essentially, if somebody dies of a hypoglycemic event while they're attached to an insulin pump, that pump will get sent to the FDA or Health Canada or the regulatory body of that company. And in the United States, they've found 3 cases over the last 40 years of a true event where an insulin pump just gave too much insulin, and that was what caused somebody to die or have significant harm. All 3 of those were associated with one particular pump that is extremely obsolete to begin with now and was also actively recalled by the manufacturer. So it's very, very unlikely that it was genuinely a problem with that person's insulin pump, or the insulin pump did something unexpected, causing it to deliver too much insulin. What's more likely is, and again, this is not to put it on the individual patient, but it tends to be user error. So either somebody miscalculated how many carbohydrates they ate, so essentially figured they were eating a lot more carbs than they were, so they took too much insulin because they were trying to cover off more carbs than they ate, or a miscalculation, so they just did the math with their bolus math wrong. Similarly, patients who have some kind of altered mental status, whether they're intoxicated, whether they're high, whether they're tired, again, just leads to a much higher risk of encountering that type of accidental insulin over delivery. Again, that is more of an issue with the user and less of an issue with the device. A lot of the newer pumps now, you can set like maximum boluses, so the largest amount, to stop you from doing something wildly incorrect and just giving massively too much insulin in one go. So errors with pumps and insulin pump failures are much more likely to result in suspended insulin delivery. So most pumps are designed that at the first real sign of trouble, they just cut off insulin delivery and start alarming. And so particularly if a patient doesn't recognize the alarm, doesn't hear the alarm, or maybe is already at a state where they're so altered that they can't deal with the alarm, it can lead to a severe hyperglycemia, especially when you think a couple hours of no insulin, somebody's sugars can be absolutely through the roof. It's quite easy, particularly if you have a failure just before you go to bed. 10 hours later, you wake up where your pump hasn't been working all night, and somebody's going to end up in ketoacidotic or hyperosmolar states. So pump sites can become occluded. So basically the site at the end of the cannula can get blocked. It can get kinked sometimes if you put pressure on it the wrong way. It'll essentially just bend the cannula. It's a very thin, flexible piece of plastic and get kinked there. Stuff can happen with the pump. Any number of things can happen. But the key take home here is most pumps, if there is any kind of concern about the pump, it's going to be just shut off the insulin and say, yeah, sort it out, do it later. So if you're having a patient that's having issues with their pump, I'd be much more concerned about them entering towards a hyperglycemic state versus hypoglycemic. So our very last slide here, dealing with insulin pumps during diabetic emergencies. And it's dead easy. It's so simple. Do not mess with the pump. So don't pick up the pump and start pressing buttons trying to figure out how to turn off the insulin. Don't try to take the pump off the patient. Don't try to disconnect the cannula. Please, for the love of God, don't try to remove the cannula from the person's skin. Like the last example I gave, right? My dinner last night, the dinner I just ate, I took 6 units of fast-acting insulin, and my basal insulin, I get about a half a unit an hour, just over about 0.6 of a unit an hour of basal insulin. The proportion of insulin that someone is going to have had to take of too much bolus insulin to put them in a hypoglycemic state, you can very quickly overcome that either with oral glucose, intravenous glucose, or if you have to, glucagon. It's not a huge amount of insulin, and just the chances of messing something up, getting something wrong, doing something incorrectly when you start messing with an insulin pump are just much higher, versus it's quite easy to overcome the background insulin that's being given there. If you have a patient, particularly a patient that's going to be in an altered level of consciousness that's presented to you there, I would be cautious of letting them operate their own pump. And that's a little bit of a judgment call. You have to understand and respect that people with any medical condition, particularly something like diabetes that requires ongoing active management, are going to be the biggest experts in their own diabetes. And they're going to know typically what's wrong and what needs to happen. So you have to use your judgment, and understanding that someone is truly so altered you don't feel comfortable with them operating their insulin pump because you think there's a real chance that they're going to do something really wrong. I want to caution you about it, but understand that would be a pretty high bar where you would need to be concerned. Someone would need to be grossly out of it, but do be aware. If something particularly bizarre or strange is happening where you do suspect that it's an issue with an insulin pump, or you're in a super remote work camp where they're having issues with the insulin pump and you do have questions about it, every insulin pump on the back has the technical support phone number, and it's almost always a 1-800. They're all 24/7 numbers. And so if you do have something where you believe that you do need to go in and mess with the pump, or start giving these technical support phone calls a phone call. So giving them a call, introducing yourself. Hi, my name's David Brown. I'm a paramedic with the British Columbia Ambulance Service. I'm on scene with a patient that has this pump. We're quite concerned that this is happening. Can you give me instructions on how to disconnect, how to pause it, whatever you're going to do there. They are a really great resource. The other thing too is pumps are quite smart, and they keep a log of everything they've done. And so if, for example, you have somebody and the family member have disconnected the patient's pump from them, you still want to make sure that that pump follows the patient up to the hospital if they do get transported, especially because typically if someone's a type 1 diabetic, they've had a hypoglycemic episode, they're back to normal and they're getting transported. Typically it's going to be because it's an unexplained hypoglycemic episode, and having access to the pump and being able to look through the logs and understand what happened over the last 2 to 3 hours can really help fill in and paint that picture. So that is all I have specifically to talk about. I know the last time we did a diabetes related presentation, I think the Q&A we did afterwards probably stretched on an extra half hour with all the other stuff. So really opening up to questions now. While people are thinking or typing, I'll throw some quick plugs in here. If you are new, this is part of our weekly lecture series. We do these every Monday. We've been doing it for a year now, accepting holidays. If somebody from your division forwarded this link on to you, it was a brand new thing to you, you haven't seen these before, you're not on our mailing list, you can give Anna our DS an email, astefik@div176.ca. She'll get you on our email list. It's 2 emails a week, nothing more, nothing less. We do also post all of these onto our YouTube channel where you can watch them again. And again, we do also offer these as credits for EMALB for those of you who carry licenses there. Stop my screen share so you can see my smiling face again. One last time if there's any other question. Well, if I've effectively babbled you all into submission, thank you guys very much for coming. Anna, I don't know if you have anything else you want to add on there. Oh,
there's a question.
Kyra, no, the great question. So Kyra asks, do people build resistance to glucagon with subsequent administrations, or is it just as effective each time? So the short answer is no, because glucagon is a naturally occurring hormone. Like you have glucagon flowing throughout your body all the time. It's part of your body's natural response system. It like in a normal human being whose whole system and functions effectively, your body will start to notice, like when you're getting a little, hangry, hypoglycemic, your body will notice that, and your pancreas will secrete some glucagon to cause the liver to release it. It's a naturally occurring hormone. It's there in your body every time. So you don't become more resistant to it. No, that's right. Insulin resistance is a bit of it's a multifaceted issue, but a lot of that comes with the fact that it's a mix of lifestyle factors and the fact that insulin is a synthetic that doesn't perfectly match the human, whereas glucagon is much closer, like it replicates the hormone. It's a long answer.
What about stale dated?
Pardon me?
What about stale dated?
The most correct answer that I'm going to give in my official role while I'm wearing PIPs and a St. John ambulance shirt is that we should never provide expired medication. In a personal standpoint, I would not be afraid of using something that had been stored appropriately a month afterwards on myself or a friend or a family member. But as long as we're talking at a St. John ambulance level, the only answer I can give there is that any medication past its expiry date should not be given. Any other questions there, if anybody? I think Anna sent my email out in one of the invites to this. Obviously, if you have any questions about any of this, or the same, if you have feedback, stuff that you want to see more about, stuff that you thought I talked about too much, anything that can refine this presentation, please don't be afraid to send me an email, get in touch. I'm happy to answer questions. And similarly, as we're moving forward into the world getting back to more normal, and we're resuming in-person training, always happy to freelance out to other divisions if you want to do something a little remote about specific to diabetes. I'm happy to come in as a portable subject matter expert. I'm just going to chime in here. Nancy quickly just asked a quick question. Any special storage required for the devices? So most insulin is good at room temperature for about 30 days. So the insulin pens are good for 28 days outside of the fridge. So most people keep all of their vials of insulin except for the one that they're actively using in the fridge. The extreme heat, like over about 30 degrees, starts to degrade the insulin within the pump. So you don't want to leave it laying out in the sun. You don't want to put it in the oven with your lunch for some reason, stuff like that. It's about the same temperature things as an iPhone, actually. A lot of people will put theirs right next to their iPhone because if the iPhone gives an overheating warning, your insulin's probably getting too warm. And the newest generation of pumps too also have heat sensors in there that'll warn you if it's approaching being too warm. But the pump itself doesn't require any specific handling or care otherwise. Kyra's question there. The only thing that I cannot do as a hard limit as a person with type 1 diabetes is that I can't join the military. They just won't take me. There's no universe under the sun. The Canadian Air Transport Safety Authority, I can't remember what they're actually called, only fairly recently allowed people with type 1 diabetes to get licenses as commercial pilots and as air traffic controllers. Like that was within the last, at least a year, I think maybe even less, the past 6 months. I have, every so often when I'm sitting in my car shooting up insulin into my stomach in the parking lot of a restaurant right before I go, absolutely to town on a burrito, every so often I'll have people give me some like side eye through there. It's not something I've personally experienced. I know some people have. I'm also very lucky to exist in a group of people that is largely either people that love and care about me, or people that are healthcare workers, and the same at work. I work around healthcare workers, so I think a lot of those stigmas are removed. A lot of people understand the basis of what I'm doing. I know there are a lot of people out there that do have discrimination in the workplace against having to have their phone, for example, to monitor their glucose, onto their cell phone, having to take time off to do insulin injections, being made to do their insulin injections in the bathroom instead of in a public space because people are uncomfortable with seeing the needle. It does happen out there. There's some really good organizations out there that are working to help resolve that. And Juvenile Diabetes Research Foundation and Type 1 Canada are both really great organizations that deal with that and do a lot of advocacy. And JDRF specifically, and this is a bit of a tangent, my apologies, actually has a program where, like for children who are diagnosed while they're still and specifically targeting children who are diagnosed in elementary school or attending elementary school with type 1, they actually have a program where they'll come in and teach anywhere from a classroom up to like a full school assembly and do a whole like diabetes awareness and understanding presentation, so it becomes a more normalized thing for people to understand. It is technically, I think, accepted as a disability within Canada. I'm not eligible for disabled parking. I was disappointed to hear that. But it is eligible for certain things like the Canada Disability Tax Credit, some of the disability tax relief that came through COVID. I won't call it perks because I don't know that there's perks to a chronic disease, but within the context of having it, there's little things that make your life a little bit better. Exercise is good for diabetics, but you know what? Exercise is good for everybody. Like, as much money as we spend on preventative health care within the country of Canada, like if everybody in the country went out for an hour-long walk twice a week, we'd be a healthier country. We'd cut our healthcare spending by a huge amount. I won't pretend for a second that everybody needs to be out there running half marathons every other weekend, but like even if that's something you wanting to do something to improve your health, like drink more water and go for a couple big walks every week. It's medical advice from David Brown. Don't do drugs and go for walks. Oh, I'm not saying anything about less wine. Don't put those words in my mouth. Kyra asks if type 1 is genetically inherited. So type 1 is there's a lot more detail if you want to go back and watch the diabetes presentation I did a few weeks ago. So type 1 on its own is a autoimmune disease that's typically brought on by a viral trigger that sets the autoimmune system within the body to create antibodies that attack the beta cells in the pancreas, which produce insulin. There is some genetic link to it. Like children of people with type 1 have, I think, about a 5% higher likelihood of children of people without type 1. But in identical twins, type 1 is only about a 50% co-occurrence rate between identical twins, whereas actually type 2 is a 90% co-occurrence rate between identical twins. So there tends to be stronger genetic links within type 2 than there are for type 1. There is, and again, this is getting to the edge of stuff that I'm really confident talking about. There is some genetic link between overall autoimmune. Like both sides of my family have a relatively extensive history of autoimmune disease. My maternal side has quite a bit of thyroid disease. My paternal side has a few other ones, although I'm the only type 1 diabetic that anyone in our family is aware of. Well, thank you guys all so much for coming out and listening to me talk. It always amazes me a little bit when the viewer count stays the same the whole way through or sometimes goes up. Like we said, these are on YouTube. If you have any questions about this going forward, anything that's not covered, send me an email. As you can probably tell, I'm more than happy to talk about it. It's something I'm passionate and enjoy talking about, and Anna can attest that I enjoy talking in the first place. So.
All right, thanks, David. That was a really great talk.